Dr. Khatoj, Professor Reddy, Dr. Kabir Sheikh and friends. First of all, I would like to congratulate Dr. Reddy and his team for organizing this very important conference, and as Dr. Sheikh said, it's really a surprise and a welcome surprise to see so many people. In fact, we're losing out on space because of that. Perhaps we needed a bigger auditorium, but it is very heartening to see that a subject as apparently dry as this attracts so much attention. I think as my starting point, I'll just read out something which I pulled out from the internet, which is the definition of HPSR as given by the Alliance for Health Policy and Systems Research by a gentleman called Mills. And quote to quote, health policy and systems research is defined as a field that seeks to understand and improve how societies organize themselves in achieving collective health goals, and how different actors interact in the policy and implementation processes to contribute to policy outcomes. I think it's a very comprehensive and, shall we say, it actually gives an indication of how problematic the whole thing is, because it's talking about processes, it's talking about policy, it's talking about systems, and it's talking about outcomes. By nature, it is interdisciplinary, a blend of economics, sociology, anthropology, political science, public health, and epidemiology that together draw a comprehensive picture of how health systems respond and adapt to health policies, and how health policies can shape and be shaped by health systems and the broader determinants of health. So that is actually the challenge before us, and I think this conference has been organized at a very topical time, because with the change in government, we are looking at a change in policies and maybe a change in systems as well. We are looking actually at drawing up a new health policy, because the first health policy was drawn up in 1983, as you know, and then in 2002 we revised that policy. But now a lot of water has gone under the bridge since that. So many new technologies have come, so many new diseases have emerged, so many new ways of tackling these diseases are before us, new vaccines have been introduced, so on and so forth. So really the time is right, but this policy of ours, because it will need to be drawn up for a fair length of time, so it needs to be evidence-based and evidence-driven. For the moment, we are looking at a very short time span of 6 months to have the first cut of the policy in place, but after that I think Dr. Kabir and his team will come into play, and after the first cut is on the internet, they can look at the various constituents and elements of our policy and guide us on the basis of evidence in shaping and honing that entire policy. I welcome Dr. Nata Manavde to our conference, and she will be chairing the next session. Well, I was just thinking of some of the ways in which evidence has shaped policy or even the practice on the ground, and out of my experience I could draw a couple of instances. For instance, polio. Polio encountered a lot of problems in places like Rampur and Moradabad, as you know. And the main problems were coming from the Muslim households because of the amount of misinformation and rumors that were circulating that this polio vaccine is actually meant to render a particular section of the society infertile. So what was done in order to combat this? There was the help was taken of faith-based organizations as well as people. So the Maulanas and the Mullahs, they were encouraged when the evening prayers were held, when the azan was called out, and when they made their when they preached their sermons. Not only that, at that time also, and then quite often they went door to door in order to convince people that this was not the case, and slowly people came around. And it was a lot of persuasion, it was a lot of one-to-one communication. So that is one example of how this entire program became successful over a period of time. Of course, it took us about 20 years to get rid of polio. But nobody expected it to happen, because just 3 years back we were contributing more than 50% of the polio cases. And today, touch wood, we are polio free. And we intend to remain that way. But this is one interesting example, I thought, of how policy and program can interact with the realities on the ground. AIDS is another example. Now, AIDS, we've had a lot of success. The incidence of AIDS has come down by a whopping 57% over the last decade, from 0.41% to 0.27%. And one of the reasons this was done was that AIDS has been one program which has been very quick to have its ear to the ground to see what are the different ways in which the disease was spreading. And one of the ways it was found out was because of migration. So a number of studies was done. The Surat to Odisha corridor was mapped. The Mumbai to the east of UP, that corridor was mapped. In fact, it was found that there is a bus which is known as the Mumbai bus, which goes from Behraj and travels overnight and over day to reach Mumbai. So that was how it was found that because of migration, a lot of the disease was still spreading, and spreading slowly and subterraneously, so to say. So after that, a whole program was built to target migrants, so much so that the migrant movement was mapped. It was found that there were certain trains, there were certain buses which were more crowded than usual because they were carrying migrants, and then they were approached with, for something to make it interesting. They were given a bag with a comb and some toiletries, and along with that there was some material, some pamphlets telling them about the disease and telling them how to avoid it. And that was one strategy, I think, which has been quite successful. Now, my third example is something which you can all read about. It recently came out in The Economist, and it talked about open defecation in India and called it the final frontier, and how at the moment there is a great need for toilets, but just building toilets will not do because of the culture. There still is a lot of belief in the rural areas that it is healthy to go out and defecate in the open. And not just that, there are also caste considerations and so on. So even where toilets are built, we know this from personal experience, that instead of toilets being used, you find hay being stacked out there, and people are not using them. So it's not just a question of building toilets, it's also a question of mindset. So India, actually, with its diversity, where it is said that every coast there is a different dialect, there is a different diet, there is a different culture. So the whole aspect of health policy and systems research, it comes into play, but it really gives you an idea of how enormous the challenges are. I'm glad this challenge has been taken up. And in fact, in our NHM, National Health Mission, we have earmarked 1% for this activity, and I would request Dr. Sheikh and his team to be in touch with Mr. Manoj Halani, who is the Joint Secretary, so that you can come on to the same page, the same platform, and we can take this forward and see how it feeds into our policy and programs in the future. Thank you.